Hi class. So we're going to be talking about diagnostic screening this week. Some of this we've actually already talked about in the prior weeks. So some of this will be refreshed, but we just go into it in a little bit more detail. So hopefully you guys learn a lot this week, and some of this, yes, will be on your final exam. So be sure to pay attention to some of the highlighted portions and to listen to each slide. So we've talked about screening a lot, and this is just a definition sort of the purpose of screening, and that is to detect disease during the preclinical phase, like we talked about in the prior lecture. Because during the clinical phase, the patient is aware of the problem and even without screening will seek medical care for symptoms. So there are some differences in screening tests and diagnostic tests. Screening tests, obviously, we're using to identify asymptomatic individuals, and diagnostic tests we're using to determine the presence or absence of disease. So many of you already know your diagnostic tests like x-rays and blood work. Now, x-rays we don't typically do screening with. We don't utilize x-rays for screening. That's potential for more harm than good because we're exposing patients to radiation. However, when you go to your physical exam, oftentimes they will do routine blood work because the potential for harm and the risk is quite minimal to nothing, and we can use it to identify asymptomatic individuals. So the diagnostic test is performed after a positive screening test. So we don't just order x-rays or CTs or MRIs or anything with radiation. We don't order special lab work to detect cancers or HIV or STIs in the situation of asymptomatic individuals. So this is just a question to prompt, your thinking. What are some common clinical screenings that you guys can think about? They do physical exams, they do blood work, just to get a baseline, your baseline labs. What are your baseline labs? Those are your CBC, your CMP, your A1C. What are some other ones that you can think of? So we do some common clinical screenings for pregnancy, prenatal screenings. There's the glucose screening to detect gestational diabetes. There's newborn screening for for Down syndrome. There's, of course, we already talked about blood work. Cancer, in the past we've prompted or educated the public to do self-breast exams. We actually don't encourage that anymore because what we've found through surveillance and through research is that more patients are finding what you would call like a fibroadenoma or a benign cyst or lump, and we're actually causing way more financial, emotional harm than we are finding breast cancers. So interestingly enough, we actually stopped advising people to do self-breast exams. Other exams would be, colon cancer screenings like we've talked about in the prior lectures, prostate. Blood pressure. When you go to the doctor for your routine exam, they always take your vital signs. They'll take your lipid panel to look for cholesterol, again, A1C. Osteoporosis. We do screenings for women over the age of 65 typically, and then if they're a little bit younger but with some significant risk factors, we'll screen them for osteoporosis with what we call a DEXA scan. So it's basically a whole body x-ray measuring the density of their bones. Glaucoma, so again in the elderly, looking at their eyes during their physical exam and assessing their vision and hearing. So what are some of the epidemiological purposes of testing? So one is for screening, so we're trying to find out who in a population has the disease, how the disease is transmitted, how it develops, looking for early detection and intervention, primary or secondary prevention methods, and this usually involves mass screening of symptom-free persons. When we're looking at the clinical side of things, we're trying to determine the probability that a disease is or is not present. We're trying to assess the severity of the illness, predict outcomes, and monitor responses to therapy. So you guys have already been exposed to these terms, validity and reliability. These terms are used to describe the accuracy of a test. So validity is the extent to which a test measures what it was actually intended to measure. So in other words, to indicate which individuals have a disease and which do not is an example of what we might be testing. For reliability, we're looking at precision. So is the test dependable? And when we say dependable, we mean, can we reproduce it? Can we use the same test in a different setting and get dependable results? In this case, a reliable test would mean that random errors are not present. So the ability to distinguish between who has a disease and who does not. You guys, we've already talked about sensitivity and specificity. Again, sensitivity is the ability of a test to correctly identify those who have the disease, and specificity is those who do not have the disease. So there's quite a few consequences of a false positive screening. If you were told that you had HIV but you didn't, it would cause a large amount of anxiety, worry. If you told anybody about it, obviously a positive label of this disease would be hard to erase. If you had told a friend or another individual that a test had come back positive for HIV, but then you found out you didn't, it would still be hard for some people to not have reservations. Also, there's a large burden on the healthcare system. So, as you've seen, sometimes individuals who are screened positive for, say, MRSA, they have to get put into a private room. Even when they no longer have MRSA, we have to go through the process of making sure that they don't. And that can be costly. It can be costly of money, but it can also be costly of time, right? And finding that patient to bed, it delays throughput of patients through the hospital, through the emergency department, then to their room, then hopefully discharge. It delays all of that. So how significant is false negative screening tests? Well, it depends on the nature of the disease and the severity of it. The effectiveness of available intervention measures. If you have a false negative for, let's say, prostate cancer, that is a severe disease to have a false negative for, and how effective are our intervention measures? What are the intervention measures for prostate cancer? Well, it's usually chemo, radiation. Loma Linda happens to have a proton center, so we can actually use that proton therapy for prostate cancer specifically, but also surgery and removal of the prostate. And there's also post-op complications like incontinence. Intervention time frame. So if you have a false negative, what is the likelihood of the severity of the disease getting worse the longer that it goes on? And is the effectiveness of treatment greater if the intervention is administered early? So we're using prostate cancer as an example, but obviously all of these things apply to the various diseases that we screen for and what a false negative screening could be. So this is an example of true positives and true negatives. So if you look at this table here, you have screening results, you have the true characteristics of the population, of those who have the disease and those who don't, and then you have the totals on the right-hand side. So if you have a population of 1,000 and 100 have the disease, which you see in the total on the bottom column of disease, you see 100, and 900 do not, which you see in the no disease column at the bottom. But of the people who have the disease, 80 got a positive screening, 20 got a negative screening. Of the people who don't have the disease, 100 people got a positive screening, and 800 people got the correct negative screening. So when we put this into terms of sensitivity and specificity, those who have the disease who screened positive, you're looking at sensitivity. So this would be an 80% sensitive test. This test has 80% sensitivity, but it has an 89% specificity. So we've talked about cutoff points prior to this week. So this is using a specified value to sort data into categories, meaning like who has it and who doesn't. So for example, diabetes, we say that an A1C less than 5.7 is pre-diabetes, but an A1C greater than 6.4 is diabetes. So this is just a visual example of what having a high cutoff point would do. If your cutoff point is too high for diabetes, the sensitivity would go down, but the specificity would go up. So the people who have the disease, who truly have the disease, they wouldn't be included, but the people who don't, obviously you have a high amount who are truly not being included. So the sensitivity would be high, but the specificity is low. I'm sorry, the sensitivity is low, but the specificity is high. So the same is true of the inverse. If you have a low cutoff point for diabetics, you have a really low threshold. So you would end up including a lot of the people who do have diabetes as diabetics, but you would also include a lot of people who don't have it in that screening as well. So your sensitivity for the people who do have it is high, but your specificity is low. So this is just to give you guys another way of thinking about it. An increase in the threshold value reduces the probability of detecting the false positives, but it increases the probability of not detecting true positives. So what are some of the important lessons that we can learn from cutoff points? Different cut points yield different sensitivities and specificities, and the cut point determines how many subjects will be considered as having the disease. It identifies more true the cut point that identifies more true negatives will also identify more false negatives, and the cut point that identifies more true positives will also identify more false positives. So where do you draw your cutoff point? Well, if the diagnostic test, meaning the confirmatory test, is expensive or invasive, we need to minimize false positives. Or we use a cutoff point with a high specificity, so IDing those who do not have the disease. Also, if you determine that there are high consequences of missing a case, so fatal diseases would be an example, we need to maximize the amount of true positives. So we need to use a cut point with high sensitivity, identifying those who have the disease. So what are some consequences of a false negative? A false negative could result in death if the person has the disease but is informed that the test result is negative, if the disease is serious, or if there is ineffective intervention, or if there isn't an effective intervention available by the time that they get to this to the stage of realizing that they have it. So when we're screening for diseases, we need to first use a highly sensitive test, and thereafter we use a highly specific test. So we always first use a highly sensitive test, and anything after that we use highly specific tests. So using multiple tests can be a good thing as long as we're using multiple different tests. But we don't want to keep repeating the same test over and over. They can be done sequentially or simultaneously. Typically, x-rays are ordered before MRIs or CTs or things like that. But the choice is based on the objectives of the testing. So the setting, it depends on the setting you're in. Are you in an urgent care or are you in an ED? It also depends on the cost, depends on invasiveness, how much radiation. Are we talking about inserting lines, things like that? Now, obviously, in some situations, simultaneous testing is necessary. Like if somebody comes in for chest pain, we're obviously going to do blood work and an EKG at the same time. We're not going to wait for one before the other. But again, it just depends on the circumstance that we're in. If we're just doing routine health examinations, obviously we're going to start with least invasive. And if anything comes back from that, then we'll order sequential testing. Obviously, performing sequential testing versus simultaneous testing is actually potentially more efficient, again, excluding emergency situations, because you have a high possibility of performing fewer tests with more cost efficiency. So sequential testing, again, is typically less expensive, less invasive, less uncomfortable. So for example, a testicular palpation before expensive or invasive testing, like an ultrasound, for example. So if we do sequential testing, does it help us further determine those who have the disease? The answer is actually no. Sequential testing increases specificity. So we're able to determine those who do not have the disease with sequential testing. So this is a practice question. During a wellness check, the nurse practitioner performs a rectal exam on a 62-year-old male and notices a small nodule on the patient's prostate. This is a possible positive screen for prostate cancer. The nurse practitioner orders a PSA test to be done in 2 weeks. The following is true of sequential testing. Does it increase sensitivity or does it decrease sensitivity? So the answer is D. It decreases sensitivity and increases specificity. Now, with simultaneous testing, the goal is to maximize the probability that the subject with true positive tests are identified. So we're looking to increase sensitivity and decrease specificity. So again, this would be really important in emergent situations like chest pain. It's positive if the results on any one more test, if the results on any one or more of the tests are positive. And it's negative if the results on all the tests are negative. So basically, if you're doing a bunch of simultaneous testing like EKGs, troponins, CKs, chest x-rays, things like that, you need all of these results to be negative in order to say that this test is truly negative. But if you have a positive on any of the results, we consider it positive. So we use simultaneous testing when it's important to not miss the disease. So it's important to not miss a heart attack when somebody's complaining of chest pain. But we do sequential testing after the simpler tests suggest disease because, again, it's more expensive and more risky and more time consuming and more costly to the patient and to the healthcare system to do it any other way. So remember, screening is a useful tool for primary prevention because we're trying to identify diseases before it produces symptoms. And again, this usually involves mass screening. Primary prevention usually involves mass screening of symptom-free people. So if you're going to do a mass screening intervention, there's a few things it needs to be. It needs to have a favorable impact on morbidity and mortality. It needs to be quick. It needs to be simple. It needs to be quick. It needs to be cheap, and it needs to be safe. And obviously, it needs to be acceptable. So, for example, does a young person with no significant family history of colon cancer benefit from colonoscopies at a young age? No. But if a 35-year-old has somebody in their family, a first-degree relative with colon cancer at a young age, it is beneficial for them to get a colon cancer screening early on. So this just gives you a visual of how much it costs for preventing one death. So for a mammography for preventing breast cancer, it costs about $50,000. For a colonoscopy for preventing colon cancer, it costs about $173,000. And again, it just keeps going from there. So your sigmoidoscopy and your FOBT to look for blood in the stool, $222,000. Again, we're looking for colon cancer. And PSA screening. Again, this is just for preventing one death and how much it costs our healthcare system. So this slide is noted the red bolded. There is an attachment on your module for this week. Please review the handout posted in Canvas. So it's important for you guys, as I stated in the last slide, to understand the different types of study designs. The purpose of an epidemiological study is to describe its distribution in a specific population. It's also to get more precise and valid information about what causes these diseases, what prevents it, and what are the appropriate treatments, and to ultimately understand its cause and effect relationship with a specific risk factor. So we all want to know what are the risk factors for getting certain diseases so that we can hopefully avoid or reduce those risk factors for ourselves. So this is the hierarchy of research design strength, meaning that systematic reviews are the number one study design. These are the ones that you want to look for in terms of strength. They give us the strongest evidence. They give us the strongest data, the most likely to be accurate and valid and reliable. Randomized control trials come second. So it's very important that you guys know the two top study designs there. Systematic reviews is number one in terms of design strength, and randomized control trials, or RCTs, are number two for design strength. So most of you have heard of randomized control trials, or RCTs. These are considered the backbone of modern evidence-based medicine. They have been used extensively to make healthcare decisions and provide current best evidence-based practices. And they usually represent the best clinical expertise. So we've seen these before, but we're just going to review them again. In terms of conducting a study, when you have a single blind study, it means that just the patient doesn't know which group they're assigned to, but the clinicians or the people conducting the study, they do know which group those patients are assigned to. A double blind is when the patients and the clinicians don't know. So there's a lot less room for bias. So double blind are usually the better choice. Single blind isn't usually really suggested. Triple blind is the patients, clinicians, and any assessors. Nobody knows which group they're assigned to. So again, it's preventing bias from entering your study. So when we're talking about clinical trials, there's two types. There's efficacy and there's effectiveness. Efficacy is the intervention is tested under ideal conditions. So does the treatment work when actually taken as prescribed? So if you're doing a clinical trial for a drug and you're looking for efficacy, we're trying to see if the intervention is tested under ideal conditions, or we're looking for effectiveness. So is the intervention tested under normal conditions, meaning does the treatment work when given to the general population? It's important to know what the stopping rule is. So when you're conducting a study and you notice that there's differences between those who are getting the intervention and the control group. So the intervention group is the group that's, say, actually getting the real medication. And then there's the control group. That's the group that's getting the placebo. If there's a statistically significant difference between these two groups, the study needs to end. Meaning if the intervention group is taking a medication that's significantly increasing their quality of life, or maybe it's curing their disease or whatnot, you can't just continue the study because the control group isn't benefiting from these effects and it's no longer ethical. So this is called the stopping rule. So we stop because one group would either be getting known, excellent versus horrific treatment in comparison. And again, it would be unethical to continue giving one group excellent intervention or deadly intervention. So just to wrap up a couple points, diagnostic tests are used to increase or decrease the probability of disease. Predictive values, these are strongly dependent on disease prevalence, thus these have limited usefulness. Diagnostic tests in the clinical settings, these are not necessarily useful for population screenings. Again, because diagnostic tests, we're trying to rule out things, not just screen. And noted what is starred and put in red, the more tests the better is not a good principle. Screening tests, sensitivity, specificity, cost, safety, acceptability, you need to understand what these all mean in terms of screening tests. So how do they affect them? RCTs, these provide the current best evidence, and the stopping rule protects patients and ensures ethical treatment during a clinical trial.